नोक चोक वाली, बिंज वॉच वाली, नॉन
Hello. Stalin sir will start by 5 p.m.
Yeah, sure, sure.
Yeah.
Yeah, good evening, ma'am. Ma'am, we are starting the session, ma'am.
Yeah, good evening. Yes.
Yes, ma'am. So, good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. Our topic for today's webinar is role of DFI in male infertility. I kindly request the participants to post their queries in the comment box so that we can have a QA session at the end of this presentation. Now it's time to introduce our eminent speaker for this evening, Dr. Runa Acharya. Madam has completed her MBBS from Rajiv Gandhi Health University, Bangalore, and MDOG from prestigious PGIMR Chandigarh. And Madam is currently working as the senior consultant fertility solutions at Medicare Fertility Hospitals, Hyderabad. And Madam has more than 12 years of professional experience in several techniques like IUI, IVF, ICSI, laparoscopy, and successfully running donor and surrogacy programs. Madam is a member of various societies like FOXY, ISAR, ESHRI, IFS, and Executive Council member for TSR since 2018. Madam is also an scientific advisory board for Merck, Cipla, and Sanzyme. She has also authored several research papers and published his research work in various international journals. Madam has her fellowship in assisted reproductive technology from Pune, and Madam has undergone embryology training and had Dr. James Catt from Monash University, Mumbai. With this introduction, I welcome you, ma'am, and now you can take over the session, ma'am.
Thank you so much for kind words and Stalin, and very good evening to all of you. So shall I share my screen now?
Yes, ma'am.
Yeah. So good evening, all of you here, and I'll be discussing about the role of DNA fragmentation in male subfertility. Subfertility, better called rather than infertility, has been showing an increasing trend year by year over the last couple of decades.
Excuse me, madam.
And hope.
Yeah, ma'am. You can maximize your screen, ma'am.
Okay. Yeah. Okay.
Yes, ma'am.
So, and I hope by the next decade beginning, we start seeing a plateau in the trend of subfertility, or at least a decline in the incidence and the prevalence of infertility, especially in our country. So now, the ISAR statistics 2019 November, our own ISAR, states that around 10 to 14% of the Indian population has been suffering with infertility, and it has been documented to be 1 out of 6 couples in the urban areas, accounting to total 27.5 million couples actively trying to conceive, are presently suffering from infertility in India. Now, if you see this data from one of the Times group, is that the male contribution to infertility has been almost similar at par with the female contribution, which was earlier, say around 2 decades back, half of what it is being seen now. Thanks to the present lifestyle and the stress related work, that this number has been increasing in spite of this being static. Now, the most important thing these days is that majority of the couples, say to the tune of 20-30%, are being labeled as unexplained, though we know that there are many reasons for that. But initially, the category for subfertility gets labeled as unexplained. So, and equal contribution from the male side is there. And unfortunately, the male subfertility yet stands to be better evaluated these days. So, when do we label them as an idiopathic male subfertility? Is when the couple has an unexplained infertility, the results of all the basic tests appear to be normal, and there is no certain reason attributed to the cause of subfertility. Now, if you go into the details and the basics, unexplained has a lot of explanations in itself. And in normal semen analysis, also 15% of the males present with actually male subfertility and gets wrongly diagnosed as unexplained or female factor. So, what are the present current day routine male evaluation? What we see in our day-to-day practice is basically routine semen analysis according to the WHO is volume, color, pH, liquefaction time, viscosity, count, motility, that is the total progressive motility, sperm morphology, the round cells, the the pus cells, and the sperm agglutination, the viability. This is better studied with CASA, though CASA is not recommended for routine semen analysis because of the little stricter identification and lower counts given by the CASA. The other slightly advanced male tests remain as the hormonal test of FSH, LH, TSH, prolactin, an ultrasound, Doppler, or a truss evaluation if required. So these are one of some of the basics tests. Maybe the first few done in a routine lab, all the gynecologists do that, and the advanced one may be recommended by the andrologist if there is a mild male factor or some other unexplained reason. Is now, what is the place of sperm DNA fragmentation in current day fertility? Are we going to recommend it in our routine day-to-day practice? And this is what we are going to know in my next slides. So coming to the factors which damage the sperm. So intrinsic factors could be the genetic, the familial, and something which we couldn't help it at a higher level, which do cause abortive apoptosis and defective maturation. But now the most important is the extrinsic factors. Now this could be structural or anatomically related, like varicocele or some local cause. It could be a systemic diseases, blood pressure, sugars, cancers, and many other systemic disorders, which again lead to a male subfertility, systemic infection or a local infection. And the most important and the present day concern is environmental and lifestyle, which includes work, which includes the lifestyle, the nutrition, the habits, all of them together. So what do all of them do is they cause a oxidative stress. So what do we mean? What happens with oxidative stress is there is certain physiological roles defined by the sperm, and it has to do that. So now what happens is when whatever the source of the oxidative stress be, maybe an endogenous or an intrinsic or an extrinsic factor, this oxidative stress causes a pathological damage, either by direct damage, by causing direct apoptosis, or lipid peroxidation, increase in the PUFA, and finally inhibiting the physiological role of the sperm, like capacitation, acrosome reaction, the activation, the sperm, the zona binding, the fertilization, and so on and so forth. So, what are the effects of this oxidative stress? Is the DNA damage, and what is the type of DNA damage? It could be a direct helical damage, that is DNA fragmentation, wherein the strands become weak and they are broken and they lose the capacity to fertilize or give a good embryogenesis. Or it could be a mitochondrial DNA damage leading to mitochondrial disorders. It can cause a telomere attrition, it can cause epigenetic abnormalities, and there are some studies which say that this DNA damage at a higher level could cause Y chromosomal microdeletions. Now, why are we talking so much about sperm DNA fragmentation? And there are lots and lots of studies going on the DFI and trying to understand how does it, come in our day-to-day practice. This is because we all know that the genetic integrity of spermatozoon or maybe a oocyte also is essential for normal embryo development. The higher level of DNA fragmentation in the sperm cells may represent a cause of male infertility that conventional examinations like routine semen analysis or a critical morphological assessment may not be able to detect. And sperm DNA fragmentation occurs when there is an alteration in the basis, which can lead to a physical break in one or the both strands. And this cannot be picked up in a routine evaluation, but it plays a lot of role in embryogenesis. So what is the etiology of this DNA damage? So it could be that there are the three main causes. It could cause an aberrant apoptosis, which is over then and there and doesn't take over something else, in further in embryogenesis, or it could be an abnormal chromatin remodeling or an oxidative stress. So what happens in the sperm chromatin damage is, we all know that sperm chromatin is essential for sperm function and subsequent embryo development. And this defects in proper formation of chromatin can lead to a DNA fragmentation and cause natural reproductive malformations like an assisted reproductive failure or a natural reproductive failure, or even if they conceive, it could lead to spontaneous abortion. And this is where it all started, that if DFI could cause a spontaneous abortion, is it working behind at the level of embryogenesis or implantation? Now, how does it work? Is there a certain oxidative radicals which are produced in a normal testis or say in a normal ovary, but the testis has a capacity with its oxidative enzymes to manage or to keep this is in balance. But when either the amount of oxidative stress oxidative enzymes come down, or the production of these radicals, the ROS radical increases, this leads to the attack on certain specific portions of the sperm, causing the sperm damage. Now, what are the levels at which the sperm damage occurs? This is a very important slide for us to understand that if the damage is at the testicular sperm, it is majorly causing an apoptosis or some chromatin abnormality. But if the damage is more at the epididymal sperm damage, this is more due to the action of the ROS, which is produced per se there. It could be because of the infection, or it could be because of certain exposure to the toxins. And this is where the basic studies or the basic concept that testicular sperm is always preferred and better in high DFI sperm. So it's the TISA sperm preferred to an epididymal sperm in high DFI. So this is the concept behind it. And we all know that the time generation ROS generation has been demonstrated to represent an important tool to predict the potential ability of the cell to accomplish the acrosome reaction. So this is the first step and the capacitation, and then occurs the fertilization. So the first step of fertilization or the sperm to egg binding gets affected with a DNA fragmentation, which is nothing but the effect of ROS on the sperm. So when we know that so much of things do happen behind, when are we going to plan testing for DFI? It's a test which is a pretty costly test, and hence we need to understand that who are the right candidates to be offered this test for. So unexplained infertility, there have been a lot of studies which say that 80% of the unexplained infertility have been shown to have a high DFI. And this is one category where you need to suspect that it could be the male subfertility alone contributing to the unexplained, and hence this is the one of the most priority conditions where you have to recommend a DFI testing. Previous unsuccessful IVFs where you don't have an answer to why it failed, looks like was all good in the embryology, all good in the endometrium, and receptivity could have been an issue. There, the sperm DNA fragmentation could also be a reason for the implantation failure. The recurrent miscarriages, lot of data and recommendations say that in recurrent miscarriages, sperm DFI has to be offered as one of the basic tests like we do for the female testing. Odds, mild to moderate odds is again an indication to be offered for DFI. Now, do we recommend DFI in men with normal semen by semen analysis before embarking onto IVF? So why are we, so this is what we will go through some of the data and recommendations in our few further slides. Now, why do we test sperm DNA? Again, to know, because it starts from impaired fertilization to slow early embryo development, impact on implantation, miscarriage, birth defects. Childhood cancers also have been associated with oxidative damage to sperm DNA as a consequence of paternal smoking. So this is one of the very good studies which has been showing the effect of paternal smoking on childhood cancers, and the reason being an oxidative damage to the sperm. So what are the benefits of testing? So this one review meta-analysis says that there has been not a proper cutoff, but they have kept a cutoff of say 25 and 50. So if the sperm DNA fragmentation is less than 25%, they documented a live birth of 33%, whereas if it was more than 50, it came down to a lower live birth rate of 33%. So this were a meta-analysis of 16 cohort studies, approximately 3,000 couples studied, with 14 of which were prospective studies, which showed that the effect of sperm DNA on miscarriages. And they found that there is a significant increase in miscarriage in patients with high DNA damage compared to them with the low DNA damage. But this study couldn't give us a proper cutoff. Now, what are the methods of testing DFI is tunnel, most preferred, the SCSA, and the sperm chromatin dispersion, that is the halo test. So these are the tests which most of the labs do a halo or the tunnel. Tunnel is more preferred test. Now, what are the factors correlating with the DFI? Now, this has been a latest study, and they say that Yang et al. Has done a lot of study on the sperm DFI and impact on the ART, on the semen parameters. So this is one of his studies which say that there is no correlation between DFI and BMI on the liquefaction time or on semen volume. And why does it say that it has no negative parameters? Is semen parameters is negative correlating? Because majority of the men, say around 15 to 20% with normal semen analysis, had a high DFI, whereas with mild to mild oat, not moderate to severe, mild oat showed a normal DFI. What are the positive correlating factors? Age. Age, we all know that as the age increases, there's a lot of epigenetic changes and a lot of things happening behind, leading to an increased DFI. Abstinence is one of the very important factor correlating with DFI. More the abstinence, more the earlier tissue, more the ROS activity in the older sperm or the dead sperm, and hence uh, abstinence is one of the major factors correlating with DFI. I would tell you again why. This is one of the major factors later. Smoking, alcohol, again the habits. Stress is, yes, one of the major contributing factors again for DFI. And this has been that lifestyle and our present environmental status do contribute a lot to increasing the DFI. This is again a meta-analysis wherein they have found that this is a study of whether the sperm DNA fragmentation could be a promising predictive tool for male infertility. So they had two meta-analysis. The first one was the comparison of DFI between infertile and fertile. They had 28 studies in which infertile men and fertile men were the volunteers. Infertile were unexplained. 15 studies in that. And mild to moderate oat, that is an abnormal semen analysis, 12 studies of that. And what they found were that fertile controls definitely have a higher sperm number compared and motility compared with the infertile. The DNA fragmentation index was significantly higher in infertile men than the fertile control, and this remained same even if the subgrouping was done between the methods used like tunnel and SCD or SCSA. Comet has a different way of working. So usual ones when they're compared, the sperm DFI method is usually tunnel or SCD or the chromatin dispersion or the SCSA. So the statistical significant difference was noted when 8 studies comparing men with proven fertility to men with unexplained infertility were considered. So majorly, even if it was unexplained and the normal semen analysis was documented, there was a difference, significant difference between the DFI of the groups. The second meta-analysis was the administration of FSH to this all the subgroup, and they found that there was a increase in the total sperm count after administration of FSH for 3 months, but there was no difference in the sperm number, significant difference in the sperm number, and there was no difference in the DFI in the two groups. So the study conclusion was that differences among the SA limits the utility of this threshold in the clinical practice, but they proposed the cutoff of 20%, and the fecundity starts to decrease when the sperm DNA fragmentation is higher than 15. So what we call as 15 to 25. So we consider 15, better consider as 15 as a cutoff and look for 15 to 25 as a fair potential. And suggested that, similarly, they have suggested that the chances of fertilization are close to zero when the DFI is higher than 30. So there are a lot of studies, and Spano et al. And there are some studies which I will tell in future. This is again, so the sperm DNA fragmentation could be a useful tool for male infertility diagnosis and management, keeping the threshold as 20%. Now, if you come to this chart, we can understand how individual correlations, if we go to, the majority of the studies wherein the DFI was compared, high DFI versus normal DFI with fertilization rate, there was a mixed reaction. Some say that the fertilization is reduced. Some say that it was no difference. Now, but if you come to the embryo quality, majority of the studies have said that there has been a decrease in the embryo quality in high DFI group. Pregnancy rates, very few studies say that no, but majority of the studies have been documented that there has been a decrease in the pregnancy rate. There has been one study which says that ICSI is better than IVF. And abortion rates, if you look at all of them, except this says that the abortion rates have been increased in men with high DFI. The sperm parameters have been found to be reduced in sperms with high DFI, especially when they are more than 30. So why is it important? Why is the differentiation between IVF and ICSI? Now that is because an arbitrary selection of a sperm by a good embryologist for ICSI could potentially lower the possibility of using a sperm with high DFI for fertilization. So this could be helped or explained further when you use IMSI for sperm selection. And similarly, in IUI, when we use the sperm optimization methods by the density gradient or max, so this technology may eliminate the higher DFI sperm, choosing the lower DFI sperms more, and this could be the reason of better results with ICSI or IUI for that matter. And DNA, again, the second step is that the DNA repair by the oocytes could be another reason why DFI does not influence embryo development or pregnancy following outcomes with IVF or ICSI. So if we compare now the DFI of 30, so we were still now talking only on the DFI between 2015. So, but there are studies which talk of the comparison with 30, that is the highest cutoff. They have found that it is very less, the live birth rates in IUI, because the sperm selection would not be that good as it would be with ICSI or an IVF. In IVF or ICSI, again, ICSI fares better or gives better pregnancy rates in men with high DFI. Now coming to IUI, this is a latest study, again a retrospective study, wherein almost 2,622 ART cycles were studied, which were IUI, IVF and ICSI. And they found that the clinical pregnancy rates were not significantly different in the different DFI groups, less than 15, between 15 to 13 and more than 30. But if you see the abortion rates, it was significantly increased from low to high and to the tune of 27.3% in high DFI. So this is very important for us to understand that if they escape and get pregnant, the chances of abortion is almost 30%. This is our own study with the SRMC in Chennai, and again a prospective observation study which on 105 males were planned for IUI ICSI. What they studied was that men with abnormal semen analysis had higher DFI, again mild to moderate OAT. There is no indication for doing a DFI maybe in the severe OAT. No significant differences in pregnancy rates in IUI cycles. But in ICSI, the pregnancy rate was significantly decreased in DFI positive. Now this could be arbitrary selection of the sperm, which could have caused a reduction in the pregnancy rate. But the conclusion was that elevated DFI significantly affects pregnancy rate in ICSI cycles. Now from all this, what are certain key points what we gather is with ICSI, the spermatozoa with significant DNA damage are more likely to fertilize the oocyte than IVF, but the miscarriage rate still remains the same. The degree of which sperm DNA damage affects the pregnancy outcome to some extent may depend on the oocyte quality. Now, this is a very important slide for us because oocyte quality is very important to know the damage. That is something which is called a sperm correction, which happens post entry of the sperm into the ooplasm. Spermatozoa themselves are incapable of DNA repair, and so they rely on the oocyte to repair post-fertilization. The negative impact of high DNA fragmentation on pregnancy can be overcome by high-quality oocytes, as shown in one of the studies comparing standard and donor. Now, this becomes a very important slide for us, which helps us to counsel the patient, wherein there is a contribution of a mild male, mild female factor, or a low ovarian or a borderline ovarian reserves, wherein we suspect a compromised oocyte quality. But what we want or we expect is a better oocyte quality, and hence the donor program should be always counseled in men with high DFI with a DOR patient. So this is because the capacity of the oocyte to repair the DNA is better in a young, good oocyte, good quality oocyte than an older, poor ovarian quality oocyte or poor ovarian reserve oocyte. Now, the last contribution from the DFI is recurrent pregnancy loss. There are a lot of studies, lot of recommendations, ASRM, ISHRE, all of them have proven and accepted the role of high DFI in recurrent pregnancy losses, and it is advised to offer DFI to all of them with recurrent miscarriages or recurrent pregnancy losses. So what is the management in high DFI is definitely the correction of extrinsic factors like varicocele, infection, antioxidant therapy at least for one spermatogenic cycle, followed by ICSI using better cell sorters or density gradient preparation for the sperm, IMSI, TISA. There is a lot of evidence. There is SWOT analysis in 2018 which says that testicular sperm is always preferred to the ejaculate sperm when doing an ICSI for a high DFI. But with the latest advancement in microfluidics from maybe 2 to 3 years, there is a change in the scenario towards microfluidics because TISA still stands as an invasive testing for male, and microfluidics becomes a cost-effective, cheaper analysis, cheaper alternative to TISA. But the most important is always lifestyle management and counseling, because we know from where the stress and where the ROS has come, and the effect of lifestyle on the DFI we can see from our lot of earlier studies. Now, this is a very important which talks about short abstinence. Now, as I discussed earlier, this is one of the positive correlating factor for DFI. So when you have a short abstinence, it's a immediately produced sperm, and this has a lower DFI. So this is very important in the practical scenario, because whenever we offer a DFI to a male for testing, it is very important that you counsel them regarding the abstinence, which should be only 24 to 48 hours max. And the same holds good when you do an IUI for a borderline DFI, or you offer an ICSI with microfluidics or TISA, that the abstinence should be very short, to the tune of only 24 to 48 hours. So just last slide on the microfluidics. So this is a recent concept spoken very highly of in this ESHRE this year, and there was an Asian study presentation which spoke on microfluidics role in the oocyte and the sperm sorting. They have demonstrated increase in the fertilization rates in case of low sperm concentration or high DFI compared to the conventional method. The application of in the IVF process is still continuing to increase. Maturation, insemination, and oocyte manipulations, along with other processes using microfluidic devices, are now fairly common in IVF ICSI. This is nothing but based on a chips with fabricated microchannels and chambers, which has PDMS, and it helps us to sort the sperms better, so that the sperms with a lower DFI come out into the upper channel and get collected in the upper well, and the sperms with a higher DFI tend to be in the lower layer and get collected in the lower well. So this helps us to select the sperms better for ICSI, and definitely it would improve the embryology and help us get a better pregnancy rate and take home baby. So what is more, I think, more important with DFI is a proper counseling. There are to be given a lot of antioxidants offered, and the patient seeks all type of protein shakes, steroids, or whatever medicines offered to him to improve his DFI. But the most important, what stands always, is proper counseling and motivation for a better lifestyle, better nutrition, and less stressful activity. Or if you cannot avoid stress, definitely motivating and counseling them for de-stressing themselves, which could definitely help us all to achieve their pregnancies faster. Thank you one and all for patient hearing.
Ma'am. Thank you, ma'am. Male fertility remains a struggle to diagnose and treat, ma'am. So, madam, with your
Yes.
presentation, we can able to understand that a couple who reach fertility specialist for a baby should be recommend for a sperm DNA fragmentation at the beginning itself, apart from the routine semen analysis, so that It can save time and the cost of treatment for the patient. Am I right, ma'am?
Yeah, maybe when you are looking into idiopathic male subfertility, we have a lot of tests we offer for a female. But then I think DFI stands at par and equally important to be offered to all the couples who have an idiopathic or an unexplained subfertility.
So, ma'am, do you recommend to do this DFI at the beginning itself, ma'am, or we can wait for?
See, I always tell that infertility would be a subfertility treatment would be something divided in three levels. So the level one is basic level, which every gynecologist does, and maybe the infertility specialists don't. Is the basic OITI cycles, the routine tubal evaluation, the routine basic hormonal testing, a routine semen analysis. But then when your level one fails and you don't have a reason to, then yes, when you are entering the level three, level two, which includes say IUIs or laparoscopies, that is where, or an investigation to understanding what could be the reason for the subfertility. There is when DFI has an important role, and in unexplained IVF failures where everything looks good, maybe a mild male factor or a PCOD or a tubal factor, where IVF has a better embryology, a better endometrium, and no explainable reasons, quote an implantation failure, and we label it as an implantation failure. There is where a role of DFI comes in to know the third party, because more than 30, my personal experience also is the embryology is not infertile, maybe okay, or the embryology total, the six to 20.
Ma'am, I think there is a internet connection with you, ma'am.
Hello?
Hello, ma'am.
Hello, Stalin. I think it got
Yeah.
this.
Yes, ma'am. That internet connection has been not stable, I think, ma'am.
Yes, yes.
Yes, ma'am. So, ma'am, we are discussing about that couples who want to go for this fertility
Yeah,
other
I
days, ma'am.
always recommend DFI at level 2 or level 3. Uh,
Okay, ma'am.
see, usually what we have patients, couples coming to us is usually after failed IUIs or failed IVFs. So definitely role of DFI comes when you have actually no answer. Want to know what could be the reason, and majority of the times, as I told the data, I showed the data. 80% of them unexplained have a DNA damage. So it definitely comes out to be hello.
Yes, ma'am. Yes, ma'am. We are on time.
Definitely comes out to be more than 25%, and this becomes uh, a counseling tool and maybe a easier decision to go for a third party if there's a lot of IVF failures.
Okay, ma'am. Ma'am, you are saying about this microfluidics, no, ma'am. If the total damage is the sperm damage is more, then whether it is if there is no good sperm, how it will work, ma'am?
That's what the percentages would be like, say, not that there will be
Hmm.
100%, right? Even in the teratospermias,
Okay.
where we see, definitely we could select one out of so many in million. The microfluidics, it's a channel based made up of PDMS. So there is like there are wells wherein you put the sample and the media, and at a flow rate of the media, the sperms with a lower DFI slightly swim up to a upper
Okay.
well, and whatever be the numbers, even if you get very few numbers, it doesn't matter, because finally you're going to do an ICSI. So some or the other, in the normal semen analysis, normal sperm sample with high DFI, microfluidics works very well.
Okay, ma'am.
With
Uh,
severe oat, with the testicular sperms, you cannot do all this sperm sorting. With microfluidics, if you have, say, a count of, say, maybe 8 to 10 million, also you could go ahead with microfluidics, and you would get sufficiently good number of better sperm. We cannot say it's a completely low DFI, but given a choice, if you have a sperm DFI which is more than 25, and you could sort the sperms whose DFI is less than 20 and use them for ICSI.
okay. Okay, ma'am. Ma'am, when come to treatment procedure, whether this testosterone injections or any other hormones will improve this DNA fragmentation, ma'am?
No, there are studies which say that, see, it's basically an ROS activity. So
Okay, ma'am.
your work should be only working on the ROS. See, if the DNA, if see the reason for the DFI high is either systemic disorders which you have to take care, so that doesn't become unexplained, like hypertension, diabetes, or some other medical disorder, cancers or something like that. Now, if it is a local cause like varicocele, yes, maybe it's a grade 4 varicocele. You may go for a varicocelectomy and maybe the DFI would come down after 3 months. Local or systemic infections, yes, infections again increase the ROS activity because the polymorphal for nucleocells, the pus cells are more and they secrete ROS. Okay, so these are the conditions where the ROS generation is more, and uh, if there is no reason, suppose it's just a idiopathic lifestyle induced, no reason is usually labeled as stress. So if there is no reason and looks like it's just a lifestyle stress or an idiopathic, where there is no correctable cause,
Okay, ma'am.
then no other work would work except the antioxidants. So the male hormones are normal, the male semen analysis is normal, there is no varicocele, but the DFI is say 25% or 23%. Then I mean, whatever you do, it would not work except the antioxidants. Antioxidants given religiously for 3 months may reduce the sperm DFI to certain extent.
Okay, ma'am. Ma'am, I don't find any other questions in the chat box, ma'am. So if you allow us, then we can end this webinar for today, ma'am.
Yes, thank you so much.
Yeah, thank you, ma'am. Thank you very much for your presence and spending your valuable time with us today, ma'am. On behalf of Shield Healthcare, I would like to thank all the delegates for their patient listening also, ma'am. So thank you one and all, ma'am.
Yeah, thank you so
Thank
much,
you,
and
ma'am.
wish you all a happy new year.
Yeah, wish you the same, ma'am. Happy New Year.
Thank you.
Yeah, ma'am. Thank you.